Okay, so thank you all for joining us for the Your Health Lecture Series this evening. Dr. Lowery and I had hoped to join you in person this evening, but we made the determination earlier this week that the weather downstate and in the Upper Peninsula was going to make travel extremely difficult. And we also learned that Dr. Lowery's flight did in fact get canceled this morning. So I think we made the right decision, but appreciate your understanding and hope to see you all in the future. I did want to take a moment to reflect on the tragic events of last week that occurred on Michigan State University's campus in East Lansing. 3 students were tragically killed and 5 more students were seriously injured and hospitalized. And we just want to take a moment to observe a moment of silence to remember the lives lost. Thank you. I will now turn things over to Dr. Robert Wynn, Dean of the College of Arts and Sciences at Northern Michigan University, to introduce the series and provide a welcome. Dr. Wynn.
Thank you very much, Mark. So first, welcome. Tonight's lecture marks the 14th year of the Your Health series here at Northern Michigan University. I had the good fortune to be in the initial planning meeting when leadership from Michigan State University College of Human Medicine and Northern Michigan University discussed the possibility of collaborating on a speaker series with a focus on featuring physicians and researchers who could speak on a wide variety of health issues and topics of interest to a broad audience. That series has now grown due to its success to include Michigan Tech, Bay College, Lake Superior State, and has expanded the opportunities, like the one we're having this evening, to communities around the Upper Peninsula. I'd also like to thank the sponsors of this series, Northern Michigan University, Michigan State University College of Human Medicine, UP Health Systems Marquette, and the Superior Health Foundation. And with that, I will now turn the proceedings back over to Mark to introduce tonight's speaker.
Great, thank you, Dr. Wynn. You're proving to be part of the series longer than I have, because it predates me. I've been doing this for more than 10 years, and I took it over. So I appreciate learning a little bit about how you were part of the first iterations of this. So my name is Mark Brevey, and I'm the Director of Community and Government Relations at Michigan State University College of Human Medicine. MSU College of Human Medicine and Northern Michigan University have been collaborating on this series for a number of years, and it is an extension of the Early Assurance Program agreement between our 2 schools. I want to thank Dr. Robert Wynn and Dr. Eric Adam for continuing the partnership. And I would also like to note that at the conclusion of Dr. Lowery's presentation, she will answer questions from the audience, those that are written into the Q&A feature for as long as time allows. With that, I'd like to introduce our speaker this evening. Dr. Lisa Lowery, a Grand Rapids native, received her Bachelor of Science degree in microbiology with honors from Michigan State University. Dr. Lowery received her medical degree from the University of Michigan Medical School, and she completed a combined internal medicine and pediatric residency program at Spectrum Health Butterworth, Michigan State University / Grand Rapids. Dr. Lowery completed a subspecialty fellowship in adolescent medicine at the Johns Hopkins University in Baltimore, Maryland. And while at the Johns Hopkins, she obtained a master's of public health in the Department of Population and Family Health Sciences. Currently, Dr. Lowery is the section chief of adolescent medicine and assistant dean for diversity and cultural initiatives at Michigan State University College of Human Medicine. And Dr. Lowery is an associate program director for the combined internal medicine and pediatrics residency program. She is an associate professor at the Michigan State University College of Human Medicine Department of Pediatrics and Human Development. Dr. Lowery has a servant and democratic leadership style and a passion for clinical education. She sees herself as a clinician educator, around issues of adolescent medicine, including eating disorders, gender affirming care, and reproductive health. Additionally, her passion for diversity and inclusion has led her to work on improving the learning and work environment for medical students and residents. Dr. Lowery is also developing faculty projects to enhance the skills and knowledge of faculty to have conversations around microaggression, unconscious bias, and allyship. Dr. Lowery.
Thank you and good evening. And again, thank you for those who are attending virtually. And again, that old great Michigan weather permitted me from coming up there. But like Mark and I said, maybe next year, I am going to share my screen. Oh, let's see, not sharing the screen. That always works in practice session, never works when you want it to. Let's do this again. And let's make sure I am gonna actually minimize a bunch of stuff so I can actually see what I need to see. And I'm hopefully sharing my screen. And if I'm not, please just yell out and let me know. So we're gonna talk or hopefully discuss this this evening about structural racism in healthcare. And this is actually something I've had a pleasure of developing and working and understanding more over the past couple of years. And I've worked with some of the faculty here at CHM as well, developing a structural competency course that we started this past year for our second year medical students. This is a passion of mine, and unfortunately, because I'm not in person, can't be more of a dialogue, but hopefully we'll be able to have a conversation afterwards. Objectives, we're going to discuss and review structural racism. And even though we have a premise on structural racism, I think sometimes if you put any ism in there and how the structural racism impacts our health inequities, and then some strategies for addressing structural racism. Again, I'll be sharing a variety of frameworks that have been developed over the years. I could not do a talk about health inequities without sharing this quote from the famous Reverend Martin Luther King Jr. and speaks of all the forms of inequality, injustice in healthcare is the most shocking and inhumane. And as much as we have a great healthcare system in the United States, it does have its flaws, and we'll talk a little bit about that. We have to realize how our structures, our policies, and our institutions can actually be more of an impediment to our patients than we want them to be. And then there's even the concept of how our institution as a healthcare institution could be actually structurally violent to the patients that we serve. We also, when we speak about structural racism, we also have to acknowledge the trauma that we have had to our minoritized communities. And again, some of the more famous atrocities like the Tuskegee experiment, Henrietta Lacks, J. Marion Sims. But we know over the years and over the decades that there has even been shown provider bias. And we know those biases lead to disparities in pain control, how we treat myocardial infarctions, how we may overdiagnose ADHD, schizophrenia, and even underdiagnose asthma in a variety of populations. And I will say, as I should have said at the beginning, we're going to touch on a variety of topics, and all of these topics we could actually spend months or even at least minimum days talking about them. So let's talk about race. And we understand now that race is actually an arbitrary sociobiologic classification created by Europeans during the time of worldwide colonial expansion. And it was to assign a human worth or social status among themselves as a model of humanity for the purpose of legitimizing white power and white skin privilege. And we know that race-based medicine, things that I was even taught as a medical student and as a resident, we have learned that we made some mistakes and we should promote, and those race-based markers actually promote stereotyping. And we need in research more precise biomarkers But like I tell the medical students and residents, when I trained, as maybe some of you have trained, we were told to talk, you present, this is a 35-year-old, often we use the term Hispanic, or this is a 45-year-old Black or African-American person. And we were told, well, we should do that because there are these differences in populations, and research and studies have shown that we're not different. When we talk about our healthcare system, and it's amazing how much money we put into our healthcare system. We spend a lot of money. We are big ballers in our healthcare system. So you would think we have some of the best worldwide health outcomes, but we all know that's not true. And when we look at other countries, we are actually have some of the worst overall healthcare rankings. So let's just look at some of those markers. When we look at things like infant mortality, the United States has some of the highest infant mortality in comparable countries. When we look at healthcare disparities, Black women face 3 times the maternal mortality rate of white women. And this is after you control for education and socioeconomic status. So then if I were thinking how we were traditionally taught, I would say, well, there must be something wrong biologically with Black women. It can't be what we're doing. And traditionally we were taught, okay, let's take an example of diabetes. You have diabetes. We see a higher proportion rate of diabetes in this community, let's say in community of African Americans. So traditionally what we would do, we'd go into those communities, we'd say, okay, African American people, you have higher rates of diabetes. These are the resources we're going to give you. This is what we're going to teach you about diabetes, and maybe give you a few resources. And if you know better, you do better. And then we wonder why our rates are not improving. I also can't talk about health disparities and health inequities without at least briefly mentioning COVID. And I never forget when COVID first started coming across our country and across our world. And I remember having a conversation with my father, who was about 83 years old at the time. And he said, do you think Black people are going to be getting COVID? And I said, yes. And this was early on in the pandemic. And we know that the past 2 years or the past 3 years have decimated, and COVID decimated our communities of color. And for the first time in about 30 years, we've seen a decline actually in life expectancy across all races and ethnicities, but there's still a disparity. When we look at the life expectancy of even African Americans, down 4 years compared to only 3 or 4, even 1 or 2 years in some other communities. And when we look at our American Indian and Alaskan Native, more than 6 years decrease life expectancy overall. And so one of the things we think is, are we going to be able to make up that gap? I don't know. So when we think of this, then let's say, why are Black Americans, and I will put Latina, Americans, you can even substitute, why poorer Americans live sicker and die quicker? Well, if we're talking and speaking from the lens of structural racism, like I was saying, racism, not race, is a risk factor for dying from COVID-19 or dying earlier, or living sicker and dying quicker. Here is a couple of books. I actually just recently read this one, Under the Skin, by Linda Villarosa. Had an opportunity to hear her speak at this year's past AAMC conference. And this is a book by Joseph Graves. I believe it's coming out a little earlier this year. And I'll also have a slide towards the end if you want to take a screenshot or whatever and look at, but we have to look at beyond just the race, and the cultural aspects, and look broader to some systemic issues. And we're going to talk a little more about that. So what we started talking about over the past 15, 20 years are these social determinants of health. And this is something that we learned that, and this is just one matrix, and I'll show you another one on the next slide. We talk about these social determinants of health, and what make up these social determinants of health are education, not just education, but access and quality education, economic stability, such as things as living wage. We also speak of the social and community context, neighborhoods and environment, but we also then talk about healthcare. And that's what we're healthcare, and that's what I'm a part of. But if you notice, we only make up a really small part of these social determinants of health, and you need access to quality healthcare. And then this is another framework that I like because it actually really talks about food and access to food and access to healthy options. And I will say from my own lens, when I talk about my own diversity, equity, and inclusion lens, when I used to hear about food and we used to talk about disparities, we would always speak about food deserts. And then we would talk about food deserts, and we talk about food deserts in urban areas. Well, then when I was looking more and reading more about food deserts over the past 5 to 6 years, I really come to learned about the food deserts in rural communities and how, if you're in a rural community, you may have to drive 45 minutes or an hour to the nearest Walmart or whatever store brand you have up there or out there in the rural community. And then the closest thing may be the closest Dollar General. And so, but then if you look closer and you look at the disparities, so you have these food deserts, and then you have food deserts in urban areas. You have food deserts, which is a greater disparity in rural areas. But then think about when you have minoritized groups living in even rural areas. And so there can be even a larger disparity. And why should we care about this? Because social determinants of health really impact morbidity, mortality, life expectancy, your overall functional status. And so when we look at healthcare, by the time they get to our doctor's office, we are really only impacting about 20% of their overall health and well-being. I cannot be a pediatrician at heart without talking about adverse childhood experiences. And again, this could be a lecture in of itself. When we talk about adverse childhood experiences, which include physical and sexual abuse, neglect, household dysfunction, such as mental illness, substance abuse, incarceration, and divorce, we know that these things that happen early in childhood can impact our health later in life. And we also know that generational, they can have an increase of this allostatic load. Well, why do we care about ACEs? Because we know, like I said, these long-term impacts on health can impact development of obesity, diabetes, sexually transmitted infections, other health behaviors such as smoking or drug use for coping mechanisms. We also know if you have more ACEs, you're less likely to do things like graduate from high school, go to college, and that limits how much money you could ultimately. And so all those things combined can greatly impact or negatively impact your overall health outcome. But when we look at our minoritized communities, the majority of the minoritized communities have 4 or more ACEs. And so the thought is, and there's been data that show, even if we could decrease the ACEs by 1 or 2, we could have a savings of over $46 million just by helping and impacting ACEs, these adverse childhood experiences. So next slide, we're going to talk about is this weathering concept. And again, why am I talking about all these things outside of the patient? Because these are the things that impact the patient. The weathering hypothesis is by Arlene Geronimos, and she's out of University of Michigan. But this is proposed to explain the premature decline observed in African-American women exposed to stress, dangerous environments, general social disadvantage. And it's this presumed accelerating wear and tear on the bodies of not just African-American women, but actually minoritized communities. So if you think about a house that's been weathered and beat up and still standing, but it's taken a beating. So it's not going to be probably as functional as a house that hasn't taken a beating. And when we think about this framework, if you look here, you have these things like current structures, systemic ideologies. We look at working condition and wages. We look at the communities. Then we look at these individual behaviors and actions, and they all have this cumulative impact over time that can lead to, and then so you have this biologic and environmental interactions that can lead to this physiologic adaptation or disruption that can lead to this allostatic load, this aging, this increased disease risk, which ultimately can lead to poor health outcomes, poor less life expectancy, and health inequities. So then let's talk about something, your zip code. Your zip code, we know, is the most important predictor of health and well-being among all zip codes. And we know that all zip codes are not created equally. Hopefully we can agree on that. So I'm going to show you just a little bit. Now this is Grand Rapids. So this is actually, and you can actually on your free time, you can look up Richmond, not even past, and they have over 300 cities. I've looked, Marquette or Houghton weren't on there, but this is Grand Rapids. And why is this important? So if you look at the white side, this is actually a map. And if you look, this was a map created about in the 1930s. And this actually also gets in the concept of redlining, which we won't go into. But this little red area here is actually where I grew up, born and raised. My parents still live in this area. Well, this is Grand Rapids, like the 49507 area. And if you go on the website, you can actually dial it down into actually street levels. About a mile and a half east of where I grew up is East Grand Rapids. And so about a mile and a half, which actually I can walk it if I don't even think it's never seemed like a mile when I was growing up, about a mile and a half, you go into East Grand Rapids, and then there's an area even before you get into East Grand Rapids. And when you go across, not only does the socioeconomic status change by $40,000, $50,000, even $60,000, but the life expectancy changes. So if you look in this area, the life expectancy is about 70. And most people are like, okay, 70, all right, that's not bad. Life expectancy, when we look in the green areas, 85, 90, 92. So what happens in that mile and a half? And so that's a huge disparity. That's a huge life expectancy disparity. And so when we look at some of the structural contents, then we have to look at racism and many other isms, but we're talking tonight about structural racism as a core social determinant of health and as a driver of health inequities. So let's talk about racism. And one of the things, racism, when we talk about racism a lot, we get very uncomfortable. We start shifting our seats because it can be a very uncomfortable topic. But I challenge you to say, if we talk about race and racism in a very poignant way, we can then have these full-blown conversations. And then that helps us also talk about the other isms and other things that hopefully we can address. But racism, this is just one definition, but it's the belief of superiority of one race over another, which often results in discrimination and prejudice towards people based on their race and ethnicity. At its most basic level, racism is a lens through which people interpret, naturalize, and reproduce inequality. So then we're going to talk about these different levels of racism. The institutional racism, it refers specifically to racially adverse, often discriminatory policies and practice that are carried out with and between individual, really at the state or non-state institutions, or at just overall institutions on the basis of a racialized group membership. When we talk about structural racism refers to the totality of ways in which society fosters discrimination via mutually reinforcing inequitable systems like housing, education, employment, benefits, media, healthcare, criminal justice, and etc. that in turn reinforce discriminatory beliefs, values, and distribution of resources reflected in a history of culture and in the interconnected institutions. So we all have to agree that we only have so many resources. We only have so much pie. But we also have to understand that the pie is not equally distributed. And when we talk about, and this is a framework by Kamar Jones, who's done just a shiro in this area. But when we talk about why this is important for our health, when you have this internalized, institutionalized, and also this personal mediated effects of racism, this can lead to poorer health outcomes. So let's continue to look at some frameworks. So how does this work? There's this intersectionality. And again, it's really sometimes when you try to think of things in a structure or in a global way, it's a little mind-boggling. But we'll talk a little bit about this, and I'll try to identify some areas. So when we think about structural and institutional racism, a lot of times it's in the policies, it's in things that impact us, it's in the community factors and institutional factors like redlining. And then we talk about we'll talk about the personal mediated racism. And that's the one a lot of us, it's kind of easy to understand. You don't like someone because of their race. That's a little, and then we'll also talk about these intrapersonal processes where people, especially minoritized people, internalize racism. And it's all woven together. I also want to talk about this vicarious racism. And vicarious racism is indirect exposure to prejudice or discrimination that is experienced by friends, family, and even strangers. When this has been experienced, even children and adolescents can have these bodily responses that can have negative socio-emotional and mental health. Let me give you a recent example. And we've had unfortunately, a ton of examples, but I'm just going to bring up George Floyd. And the reason I bring up George Floyd is because I started my new position at Michigan State in April of 2020. So right in the middle of a pandemic, weeks later, we had George Floyd and a lot of other incidents. But what happened is a lot of times where that hit home for a lot of minoritized people is because we could see or envision or had a friend or ourselves have been stopped. And so that is some vicarious, so you can have this visceral response. So we also have to be mindful. So you're like, okay, well, why do I need to be aware of that? Because your colleagues can be experiencing this hurt, this harm. Even though it happened even hundreds of miles away, there's this visceral response, this angst that can be welling up in individuals, especially when we think about our minoritized communities. When you think about, I hear our students talk about when the policies that are going on and things that happen in the border, and how for some of them that's very triggering because of them or even their relatives. And so we have to be mindful of these things, and these things that are not only the students that we train, but our patients that we see in the room. And so I'm gonna show you a video that's coming up, and I'm gonna challenge you. It talks about the 4 eyes of oppression, which again are kind of similar to what we talked about, this institutional or the structural, which we can get, or systematic, ideologic. We can talk about this institutional, this interpersonal oppression, and internalized. But I would challenge you not only to listen for when it talks about oppression, but really, I like the video because you can actually substitute the term racism in it when it talks about speaks about oppression.
Oppression.
Yep.
It's a word that's often used as a blanket term, but there's actually a whole lot more to it. There are 4 interlocking aspects of oppression: ideological, institutional, interpersonal, and internalized. And it might seem like a small difference, but it's very important to be able to distinguish between each kind, because understanding oppression is the first step to fighting it. Let's start with the core at the heart of every form of oppression: ideology. Every system of oppression comes from the idea that one group is somehow better than another. Ideological oppression starts when the dominant group associates positive qualities with itself and negative qualities with the marginalized or othered group. Ideological oppression describes the deeply ingrained social root of inequality. It's the larger overarching idea that leads to the isms. For example, the idea that black people are dangerous is ideological racism. The idea that poor people are lazy is ideological classism. Ideological oppression leads to institutional oppression. Institutional oppression is the way that systems and institutions manifest the dominant ideology. Institutions control access, who is able to get to what and how. This includes legal rights, police practice, access to medical care and education, public policy, political power, and media representation. For example, when women make 2/3 of what men make, that's institutional sexism. When a building is constructed without wheelchair ramps, that's institutional ableism. All of this leads to interpersonal oppression. Interpersonal oppression is probably the easiest to recognize because it happens all around us. Interpersonal oppression is the way that people play out discrimination and violence on each other. It can take the form of microaggressions, jokes, stereotypes, and harassment. For example, when a student is bullied for being gay, it's interpersonal homophobia. When a Muslim person is told that they're a terrorist, it's interpersonal Islamophobia. And all those forces, ideological, institutional, and interpersonal, lead to internalized oppression. Internalized oppression is the way that people with marginalized identities internalize narratives of their own inferiority. It's what leads people to feel less than. This is the end goal of oppression. The oppressive party doesn't need to exert force any longer because the marginalized group is enacting oppression on itself to maintain the status quo. It's important to remember that it's never a marginalized person's fault that they feel internalized oppression. It's simply what happens when someone faces negative stereotypes, low expectations, and ongoing discrimination. So, for example, an immigrant feeling embarrassed about having an accent is internalized xenophobia. When a trans woman feels that they can never be a real woman, that's internalized transphobia. So, to review, the 4 I's of oppression are ideological, institutional, interpersonal, and internalized. Each of these types are interconnected and completely supported by the others. They can never exist on their own and can even be seen as a cycle. Now that you understand the different kinds of oppression, you're even more equipped to fight it. Don't forget that any effort to dismantle oppression should aim to address it at all 4 of these levels. Thanks for watching.
All right, so I like that video because even you have the Legos and the little ducks, the information I think is kind of, it hopefully breaks it down. And so when we think about our health equity framework, and how racism can interact with all of these, and then you think about these are really our social determinants of health, and they can impact our health outcomes and health inequities. So if you've ever gone to a lot of diversity, equity, and inclusion talks, so often you'll see, I call it the iceberg of DEI. This iceberg actually is talking about racism. And I think what's hard for some people to comprehend is when we think about some of these structural racism, things like that, when we think about racism, again, it's that interpersonal racism or these microaggressions or when people say things. But when we think about this institutionalized and even structuralized racism, it is all the things. It is redlining. It is inequity in schools. It is gerrymandering. It is educational disparities. It is, the healthcare disparities. It is all of these things that interact. And it's hard. And sometimes it can be overwhelming because you're like, well, where do I start? And we'll talk a little bit about that. So structural racism, it leads to differential access to goods, services, and opportunities. It can lead to residential segregation. It's our criminal justice system, mass incarceration, policing policies. So we always now talk about the why. We should always be asking why. So when we talk about mass incarceration, when we think of our minoritized communities, African Americans make up about 14% of our community, but make up 40, 50% of those incarcerated. Why? And so it's easy to draw the natural assumption, well, Black people make more crime, commit more crimes. And we know statistically that's not true. When we think of our American Indians and Alaska Natives who were removed from their land, put in boarding schools, but then they have generationally higher rates of obesity, depression, substance use disorder. And then we think about our immigration policies that continue to impact our people here that are here in our country. So when we think about from a healthcare, we talked about that. Interpersonal racism, it can cause anxiety, depression. Structural racism can have adverse birth affect outcomes. Remember, it's that allostatic load. I'm having to deal with so much. It's that increased risk for chronic disease like hypertension. It's that increased exposure to air pollution and inequitable housing. And then that internalized racism is, again, when I'm feeling all this, but then I'm also getting these messages, is also associated with depression, psychological distress, and then again, a poor metabolic health outcomes. So one of the things about racism, and again, another person who's done a lot of work in this area, Beverly Tatum, has said, cultural racism is like smog. Sometimes it's thick and it's visible. Sometimes it's less apparent, but day to day, we are always breathing it in and out. So health inequities, we know that pie, that healthcare, that whatever those resources are, we have limited resources. And we also know that the resources are not distributed equally. And so we have these inequities that can lead to disparities that to lead to poor outcomes. And when we think of why, we also have to think of how racism is woven again into these inequities that go into these disparities that can lead to poor outcomes. And so Dr. Deborah Holden used to be at Michigan State, CHM in the public health. Now she's back out east. Had this slide that talks about disparities and inequities. And again, when I spoke about that personal mediated, again, you have diabetes. Those people have more diabetes. So we need to figure out why those people need to live better. But if we really look at the inequities and not just the disparities, we're looking at how the systems and structures are unfair. And we have to look at not just the race, but we also have to look at the racism and not just go in and think of what we can do downstream, but we also have to look at things, how we can do things upstream. And so this is another image from Dr. Holden. It really talks about how we go look at not just the parity, but the social determinants of health and the inequities. So for example, and this always resonates with me, my patient can't get a ride to my office. So what do? We go out and get a grant that provides transportation, whether it's COB vouchers or other things, or partner with a group and provides my patient a way to get to the doctor. And that is great. We should still continue to do those things. So I'm not saying those are not things we should do, but I also think then we should look more upstream. So why can't my patient get a ride to the doctor? Is it because she does not have a livable wage? Is it because of she has poor credit because of predatory lending practices? Do we have a transportation system in our community that supports my patient getting to the doctor without having to wait at the bus stop for 35 minutes? And then we also have to look at the even further upstream, those systems, those laws, those funding priorities that are in place. So I'm not saying step away from doing the good work at the elbow, providing for our individuals, but we also have to look at the more systemic, the more structural things that are leading to these inequities. So what's wrong with this picture? So if I were there, I would ask you to shout out where this picture is from. And so this actually, my husband actually works in Benton Harbor. And so we know Flint had a water crisis, but for those, Benton Harbor had a water crisis. And they're in the process of changing out their lines. But my husband was telling me how, they've been delivering water and houses. I said, oh, do they have enough water? He said, there are houses with tons of water. And I think it's great that these patients have water at their homes. But why did the pipes have lead in them? Well, because the pipes weren't repaired. And why weren't they repaired? Because we don't have the money. And why don't we have money? Well, because the tax structure, and on and on and on. So again, it's great that they have water, but we need to look at the broader structural systemic barriers. So again, systemic racism, we're looking at unfair financial systems, pervasive discrimination. We're looking at differential access to resources, mass incarceration, disenfranchisement. We're looking at health harming or lack of health promoting experiences, such as inferior schools, inadequate housing, chronic stress. And then we have these biochemical mechanisms, this inflammation, these neuroendocrine processes, these vascular mechanisms that can, and these epigenetic forces that can lead to worse health among people of color and lead to health disparities. So we are now looking at and starting things to talk about structural competency. And we actually just, like I said earlier this year, or at the beginning of this year, started a structural competency course for our second-year medical students. But it really is, when we're looking at medical education and looking at it, providing attention to forces that influence health outcomes at levels above that individual interaction. And it's the capacity of health professionals to recognize and respond to health and illness as downstream effects of these broader socio, political, and economic structures. So again, when we're looking at those social determinants of health and health disparities and providing them a curriculum, we realizing that we have poverty and inequality that lead to health disparities, we also have to look at the policies, economic systems, and social hierarchies and the structures in place. And that is structural competency, looking at those structural determinants of health. So again, if you've gone to any DEI workshop, a lot of times you've seen this slide, and we know we talk about it because at reality, we all start at different levels. When people say, well, it's okay, what if they just pull themselves up by their bootstraps? Well, I remind people, some people may not have straps, some people might even have boots. But when we think about this, and when I talk about this slide, if I were there in person, I would tell you I'm 5 feet tall. My husband is 6'2". So if you gave my husband and me the same box, well, we're going to give everybody the same box. I still might have a little trouble seeing over the fence. But you know, you said, well, Lisa, you're shorter. Well, I'm going to give you another 2 boxes here. And that's equity. When we give everyone the support they need, again, that's good. But when we think about justice, it's when we're really looking at and removing the barrier so that we don't even need the supports and combination. Everything, the inequity was addressed, and the systemic barrier has been addressed and removed. I heard Dr. Irvin Vega, who's at CHM, neuroscientist, and he was doing a talk, and he again showed the slide, and he was talking about this. And then he said something. He said, but have we ever thought about why aren't they sitting in the stands? Do we ever address, well, yes, it's great that we removed the barrier, but do they want to sit in the stands? And one of my friends was sons was hearing me do a presentation. I really was from a different lens talking about this. And he said, well, Mom, what if they want to stand over here? What if these are better seats? And that's great. But what if they're never given the opportunity to sit in the stands? No one asked, well, why can't they sit in the stands? Will they ever be able to sit in the stands? So thank you for removing the barrier, but why can't I sit in the seats? So again, this is a framework, another framework that looks at microaggressions in medical education, but I think it's a great framework or how we can look at addressing structural racism by looking at the societal and root causes, looking at from an institutional level, diversity in leadership in academic medicine and leadership in the hospitals. And in a personal level, taking the time to educate the learner or even the office space or the sphere you work in. And then as an individual, commit yourself to lifelong learning about things and having self-reflection on things like structural competency, implicit bias, allyship, bystander training. And again, this can be overwhelming It is a lot. And I tell everybody, I'm committing to life. I try to be a lifelong learner. I don't necessarily consider myself an expert, but get in where you fit in. And you will realize that you may fit in a lot of these places. Maybe from an individual standpoint, it's going to a lecture at your next conference. It's attending a series like this. From an institutional level, maybe it's looking at our hiring practices. Maybe from a structural, even societal level, maybe you sit on a board or a planning committee and continuing to ask the why, the why, the why. We can create systems to identify and address bias and discrimination. We can reduce bias and discrimination and make these things a priority. We can do things like including comprehensive education in our curriculum. We can create, ensure critical diversity in our health professions. And then we can really create an institution, a climate of mutual respect and inclusion and equity, where people feel like they can bring their full, entire intersectional selves to the space. And when we've done that, that is actually a way we can work at addressing structural racism. So again, it's multifactorial. It's creating a climate of that's psychologically and cultural safety, understanding the racialized trauma and people's history, understanding person's identity, promoting even a child or provider's exposure to diversity, helping families that we take care of identify it, name it, reframe it, mitigating bias and understanding our own bias, and then identifying when we're burnt out, because we know when we're more burnt out that we're more likely to have, that's when our implicit biases show up. And then how can we make sure we develop curriculum for learners and for even ourselves, promote lifelong learning and optimize work diversity? We can do things like advocacy, address race-based medicine, reevaluate it and correct it. We can use a quality care lens for addressing racial disparities. And again, look at things as racism and race versus racism in medical education, where we look at racism and how that impacts, and then research. Over the past 5 to 10 years, we've seen more and more funding, but really not enough funding to look at things that provide and prioritize scholarship. And then my last 2 or 3 slides here, when we talk about diversity, equity, inclusion, justice, and belonging, let's always remember to ask who's in the room, who's trying to get in the room, and why aren't they in the room, and have all the voices be heard. And so it's just not saying, oh, well, they're not in the room, that's okay, but why can't they be in the room, and why isn't their voice being heard? There's so much work to be done, but not everything that is faced can be changed, but nothing can be changed until it's faced. So my last 2 slides, if you ever hear me speak on topics like this again, I usually end with this, a call to action, which is beginning with our own sphere. The work at times can be overwhelming. We have to not hide and not be afraid, and remember that change does not happen overnight and can be scary, and committing to lifelong learning. But if when we do these things, we can actually move this big ball working together, this big rock boulder, we can work together, pushing and pulling and make change. We have to be brave, be humble, be intentional, and be dedicated. And lastly, take care of yourselves, because while this work can be inspiring, sometimes difficult, it can be exhausting. So with that, I want to thank you all, and I'm hopefully leave time for questions. I'm going to leave this slide up. Not that I want you to be overwhelmed with this, but these are some of the books that I mentioned. Some of the ones, 35 Things Well-Intended People Say is a great book. All of these are books there, but if you're a podcast, Code Switch is also a great podcast to listen to. And also, if you forget any of this, please reach out to me. And I am actually going to stop sharing, I believe. Hopefully, where's my stop share? Hopefully I'm not sharing. I'm gonna try to stop sharing. Oh, there it is. It's right under the inflamed, so I could not see it. It was right woven into the book. So thank you.
Yeah, Dr. Lowery, thank you so much. lot to kind of digest there. You covered a lot of areas. We do have some questions in the Q&A, so I'm going to go ahead and ask, and if you can hopefully
I can
react
actually
and
see
answer.
them, Mark, if you want me to do them.
Yeah, if
Okay,
you
I can
want.
do that.
Yeah,
I
go
know
ahead.
I told you if I could. Okay, so do you know if there's studies that indicate how soon human life cycle wedding farm can be observed? Yes. And I'm not necessarily a expert in epigenetics, but it can even be in little kids in infancy. And that's where we see some of the and again, a lot of it may be the chronic stress onto the mom, but lower birth weights and things like that. How has learning the practice of medicine and especially caring for patients affected you as a person? Do you feel more empathetic towards issues, even global issues, because of the doctor's eye to health? Oh, wow, that's a lot. Yeah, so I'm an adolescent medicine provider, and I think I continue to learn from my patients every single day. And just kind of knowing, like, I'm a big person now of kind of knowing the narrative and knowing their story. And even if for my just kind of knowing, like, you just can't tell your patient, hey, call your caseworker, because it's not as easy as calling your caseworker to get your insurance. So I do think it has impacted me as a person. I will say sometimes, I will admit, sometimes you can be like, oh, you know, our system is broken, this is horrible, this is bad. But I think trying to be an advocate for your patient, working at that prior auth, that's going to take several days. Yeah, I think it's made me realize the world is really small. And then I also have the opportunity and the pleasure of taking care of some of our unaccompanied minors and some refugee families and just kind of hearing their stories. So it does, it makes you, it changes your vision. It does, it changes your lens. Let's see. You talked about a lecture on adverse childhood experiences and the importance of reducing these for improved lifelong. What concrete action items do you see at most important for reducing ACEs? Wow, that's a great question. I think, first of all, we have to try to identify them. And that's one thing, we have to kind of screen for them. I think the other thing is, so ACEs are really kind of hard because they're not, I can't give you a pill necessarily to impact your ACEs. But if we really wanted to do and impact the healthcare that we really provide healthcare, it's also bringing in the resources. So if you have a family that's, you know, if you screen for them, I will say, and identify them, do we have the community resources to help navigate, helping the family navigate? So if I were to say, do you have a social worker? Do you have a community health worker? Those, I think, are important pieces. And again, even though I was talking about structural racism, I do think some of the things is people have to come to us for healthcare. Is there a way that we can make healthcare and even those community resources more accessible? And so those are just, I could go on and on about that. All these are really great questions. Y'all gonna keep me here all night, which is okay. Let me see. Yeah, I think those are really important. So if I would say a concrete action item is really identifying them. I will tell you a story about 7 or 8 years ago. I did a women's conference. It was actually for our church. And this is when ACEs was really coming out. And I actually had the women, these grown women, you know, mothers, sisters of the church and all that doing, and they scored it based on their childhood trauma. And just to see, and then we had a chance to talk about it. And I really think actually even helping adults to realize these things happen to you even as a child. Let's make sure we helping you handle these as a child. All right, I'm gonna move on to the next question. I'm sorry. Thank you for your work. What if individuals and groups have difficulty understanding that structural racism even exists at the, oh, wow. Okay, April. Ooh, that is at their respective organizations and agencies. I really think sometimes, again, racism, it makes people feel uncomfortable. But I will say, even if you address it at how can we do better for the communities we serve? And I think if you have to look at how can we make our healthcare system, how can we make our educational system more equitable for everybody? And so sometimes you can't, I think for some people, they're not even ready to hear the R word, because it makes us feel uncomfortable when we hear the R. But I think if you approach it at, these are the structural issues that happen. And so why do these things exist? Why do these health disparities exist? And sometimes you kind of have to chip at it. Some people, April, are only at the point where they can address it from that interpersonal level. And maybe if you can get them to buy in there, then you can say, okay, well, let's address it at a little broader and a little broader and a little broader. But I do think it's really important that we have to understand, as great as our healthcare system is, and that's a loaded answer right there, we have a lot of work to do because there's so much dysfunction in it. We can't even really talk to each other, and so. But I think in the answer, try to have that person get in where they can really identify it. And maybe sometimes, I hate to say, you might have to even take the R word, the racism word out. And then how can we be better providers to our communities? Knowing everything that you know now, what is something you will tell your younger self? Oh, wow. Cameron, thank you for that question. I think so I'm going to make it personal, not necessarily about structural racism. I think to be a little more confident in my younger self. That's what I would tell myself now. And it's going to be okay. We put a lot of internalized pressure on ourselves. But yeah, I think I would say just stop being so anxious. Yeah, that's what I would tell my younger self, Cameron. Let's see where I lost. Okay. Do historical inequities in healthcare and means of correcting them get integrated in medical school? So not as much, slowly but surely. There is, so a lot of what I spoke about was structural competency. If you want to go to Med Portal, NEF, NEFF, there is they talk about structural competencies. Slowly but surely, we're trying to integrate them in. I think, again, we didn't even talk about social determinants of health when I was in medical school. I mean, that was 25 years ago or something like that. But yes, I think we're slowly trying to have those conversations about health inequities, health disparities, these things. The other thing I will say to your question, our students come in ready to discuss this. And this is one of the things that we've been doing. Our students, a lot of them have been out in the world, they've been done gap years, all this stuff where they come with experience. And they're ready to discuss these things. And then now the faculty, we as faculty have to go like, okay, we need to be more up on this. And so, and that's some of the things that I've been doing. But yeah, slowly, more and more schools are doing this. And actually health disparities and health inequities are a requirement for education, even for residencies. And so I've been working with our Office of Medical Education for our residency program here and how we can integrate that we have been integrating that into our residency program. What is your take on, I'm going to scroll. What is your take on the current implicit bias training happening in medical trainings? What improvements can be made? Oh, wow. Okay. We need to do better. I think, again, a lot of our students come in ready to discuss this. I think, especially, I would say for Michigan State, we recruit a great diversity of students. So you may have somebody who was raised in, urban LA. I'll just use that for example. And then you have someone who's raised in Marquette. Their experience is going to be totally different. And so we have to acknowledge our lived experiences are different. And then how can I learn from you? And we can learn from each other, because you know what, when we walk into our room, we don't know a lot of times what we're going to walk into the room. And so I really think we have to be acknowledging that. I mean, now Laura says all faculty, docs, or healthcare providers have to have that implicit bias training. I know that is something we're looking at MSU. How can we make sure our students really go through some type of training? Now, I will say, as biased as I am about implicit bias training, if that's a thing, because I do it. I don't think we can necessarily workshop and train our way to equity, but we can workshop and train our way to awareness. What are some ways to combat microaggressions in the workplace as a physician? Wow, that's a really good question. And I think being aware of it, you need to, if you're in a way, now I don't know what role you're in, but again, if you're in a leadership role, I think you can work on creating a culture. I think there's a way that you can do some things where they call calling people in and calling people out. One of the best questions that one of my colleagues, Denise Evans, she uses a question, said, when something comes up and says, well, tell me about that. Why are you thinking about that? Tell me what you think about that. But I really think you also have to develop a culture and a climate where people can hopefully be there, bring their whole selves to the space. And that's really hard, because people come with their own lived experiences. I mean, I'm in an office of 8 people in our little group, and we are probably talk about a diversity of thoughts. I can have a side conversation like there's some stuff that people are polar opposites on, but we work together. We have to respect each other. So I do think you kind of have to be able to have those uncomfortable conversations. If some ACEs are not immediately viewed or removable, are there tools that be given to young patients to be resistant long-term? I think so. One of the things is really trying to work on resiliency. And I hate to use that word because we use it a lot now, but really talking to especially our young patients and understanding their lived experiences. I am really a big proponent, especially because I work with teenagers. Tell me your strengths. Tell me what you want to be. How can I help you? How can we do that? And exposing them to the little things. I think some of them never really realize their potential. I think really helping them identify maybe your situation isn't the best, but there are ways that we can hopefully support you. Again, I don't necessarily, I work in a team, but sometimes just really talking to the patients and be like, what do you want to be when you grow up? Well, I want to do this. How can I help you? I'll use an example that had a patient that been taking care of the family. Mom called and said, hey, my patient, my child posted online that they want to kill themselves. And so we whisked the patient in, but we talked we talked about 45 minutes. This was because their parent is going to be in jail for years. And, we did a really hey, you can always come and talk to me. These, of course I did all the safety training, but really realizing, helping them identify this is it's okay to feel this way, but I'm here and let's see if there's things and we can put around you to support you. You're sly. Why aren't you sitting in the stands? I have never heard someone ask that question. I wonder if this is where it belongs in the scene. Where do you think in healthcare we can better address the issue of belonging related to access and services? Wow, that's a really great question. I think it's multifactorial. I think we have to, number one, when we're in community, ask the community what they want, and also making sure that the community feels welcome when they come. And again, so many times we go into community, go, oh, I know what works for X, even if you're from the community, but really having the key community partners. And I think then hearing from the community, why don't you come? Is it because, I don't feel safe? I don't feel welcomed? Is it location? All these things. Is it language barriers? And so I really think if patients feel welcomed, and I will say this across race, ethnicity, and genders. Again, we know there's the concordance of people. If there's that race, ethnicity concordance, people are more likely to feel like they can come to a provider and be more authentic if the provider looks like them. But I will tell you, if you can find a way to just have people feel welcomed, and then also identifying what the community really wants, I think that's where we start having them access services. And a lot of times it's getting out of the ivory tower and really and working with the people in the community, working with people who know your community. And it could be certain things like, I'll just use an example. We, as we've gone, and I will say this wasn't super easy in our practice, even with gender affirming care. You know, one of my staff said, we're going to put up pride stickers. And this was probably like 7, 8 years ago. But it was also then having conversations, some of them uncomfortable, with our staff who may not felt so affirming, but everybody needed to be open to have that conversation. All right, I'm sorry. And now I am a U of M alum. All right, Whitney. I attended DI with Monica Lipsum, who talked about recognizing racism and bias isn't enough. Beyond merely identifying injustices, what can I do as an incoming medical student to ensure health equity for future patients in our communities? I struggle to find answers to take at an individual level, that there are so many structural barriers impeding change. All right. Okay, Whitney. So one of the things is, yes, again, we have to identifying is one thing. I think for you, the injustices and inequities are going to be there. Unfortunately, I will say this, they're probably going to be there when you graduate from medical school and when you become a physician. It is just kind of our society. I really think you figure out where you want, how you want to tackle it. And for me, and I know that's like, wow. And I'm more than happy, reach out to me if you want to have another private conversation. But I think sometimes, especially I see medical students and pre-med students, they want to solve the problems of the world. And I always say, that's great. I want you to solve the problems of the world. That's beautiful. But there's also, I need you to be a student. I need you to be a medical student. I need you to get where you need to be. And still, but it may be as a medical student reaching back to a pre-med student. It may be as a medical student working on a student org. And then it may be as a resident working with medical students, working on DEI. Then maybe as a faculty member, maybe it's how can I work on curriculum? How can I be in my community? How can I work on boards and be representative? How can I be in leadership? Always being present in the room. And so it is hard, but I do think you can't, hopefully you will solve the problems of the world, but I also think sometimes you have to figure out how is it best for you to navigate that. And sometimes it's hard. I'm still figuring that out myself. So, but that's a lot. Oh my gosh, Mark, these are great questions. I mean, I could be here until like 10 o'clock and I know people can't do that.
I was just going to say the same thing. I was
like, oh my gosh, these were so great questions. So I was trying to make my answers go.
No, I was really impressed with the questions coming in, and I appreciate you, getting through all of them. I counted 13 altogether. So really appreciate your time. Really appreciate your presentation and the work you're doing, not only in our community here in Grand Rapids, but in our state. So I do want to thank our co-sponsors of the event, Northern Michigan University, and especially Dr. Robert Wynn and Dr. Eric Adam, who both helped with the planning of this, UP Health System Marquette, Superior Health Foundation, and of course, Michigan State University College of Human Medicine. And thank you, especially to you, Dr. Lowery. Thank you for sharing your expertise in this area and, extending over the hour to make sure you covered all the questions. So
no, my pleasure.
Yeah.
Maybe next time me and Mark will get up there.
Absolutely.
Maybe I'm doing it in July, right?
Right.
Weather.
All right. Thank you so much. Have a great evening.
Thank you. Bye.
Bye.